All right, so EKG questions. So we had AI generate these. These not been vetted. Nobody listened to my homework assignment. That's cool. I mean, you guys are time poor, so I understand. So let's answer the first question here. So we had AI write questions for us on ventricular rhythms, right? We wanted to start with EKG, right? So let's choose ventricular rhythm. So let's start this guy right here. Which of the following varieties of VTAC? And these are all status. And I didn't tell AI to give us 5 options. So you got torsades. I should have told it to tell us the correct answers too, but we'll think about the correct answers. Actually, let's use a highlighter. Let's be fancy. Hold on. Let's do highlight. Where's my highlight? There it is. Highlight. There we go. Okay. So monomorphic VTAC is a ventricular rhythm. Polymorphic VTAC is a VTAC, right? A ventricular rhythm. Oh, what happened? Okay. There we go. So yeah. So polymorphic VTAC, otherwise known as torsade. So really, AI doesn't know that those are 2 different things, but on the test, I know what those are. All right, you should know that those are the same thing. Right. So this is really an identification question. We should have told AI to give us harder questions, critical thinking level, analysis level questions. So we'll do that next. We only told to give us 10, so we can the next 10 we can have it make them spicy. All right. So AFib is a supraventricular rhythm, right? So I'm very visual. So I think of this as you have the atria here and the ventricles. You just separate in half. Right? And then you can even just kind of put them in the chamber. You got VTAC and you got VFib, you got asystole, you have PEA down here, and like a VTAC has 2 varieties, right? Even you can throw in PVCs down here. Okay. We got PACs up top just to make sure it's complete. We got the AV block, which is right there, right at the AV node, right? So AV blocks. We have what else is atrial? Yeah, but you can say, yeah, but SA for sinus rhythms, right? And we can then put a little category for SVT, all right, which has several different varieties, but there's 3 I want you to know, which are AFib when it's fast is SVT, AFib when it's regular or slow is just AFib, slow ventricular response controlled rate, and then rapid ventricular response AFib and aflutter are examples of SVTs, right? And then SVT got reappropriated as PSVT. Okay. Or I should say it got separated out at some point. I'm not sure when, but it was like the year 2000. But we still you'll hear people interchangeably say, oh, they're an SVT. Well, what they meant to say was they're in PSVT.
PSVT just has heart rate being over 150.
No, PSVT is its own thing. So PSVT is a fast rate with no P wave. Like, So the next semester you'll learn about junctional rhythms, and junctional rhythms are slow, kind of slow, fast, and then SVT. They're on that spectrum. Okay. So any other atrial rhythms we're missing? Oh yeah, we've got sinus rhythm. You can separate it sinus brady and sinus tach. All right, so that's just identifying, knowing where that gives you a framework. And then each one you have to know what causes it, what the treatment is. And the symptoms luckily are pretty much the same, right? If it's fast, it causes palpitations. If it's slow, it's going to cause, they're going to lose heart function. They're going to have poor cardiac output as the complication, right? So poor cardiac output is for every single EKG, right? So those symptoms of poor cardiac output, that's when they're symptomatic, right? But before that point, they might have palpitations if it's fast, right? Otherwise, they're tolerating the rhythm. How you know they're not tolerating the rhythm is either they have signs of poor cardiac output, which are what? Chest pain, shortness of breath, hypotension, confusion. And it can be any variety of those things, right? So confusion can mean 17 different things. It can be stuporous, lethargic, somnolent, semi-comatose, comatose. All right, it can be all kinds of things, right? You're trying to get something you can work with out of the classroom, so that you can, when you go to the clinicals, like, are they altered? Right? It could be altered. It could be confused. It could be not know their name. It could be not know where they are. It could be anything, but that's under altered. And then under hypotension, right? That's anything that's hypotensive. The MAP is less than 65. The systolic is less than 90, whatever they've defined as hypotensive, right? And chest pain is chest pain. I have pain here. I have pain to the right of here, the pain to the left of here, pain that radiates to my arm, pain that is relieved by, there's all kinds of things you can say for chest pain, chest discomfort, chest burning, but usually burning is, we're thinking GI. So, but next semester, I think I touch on it on Monday actually, about what is chest pain, like what is pain that actually comes from the heart, right? All right, does that make sense? The first symptoms, and then nurse interventions, how do you know someone is tolerating the rhythm? You're assessing those things, right? Do they have chest pain? Do they have shortness of breath? Do they have hypotension? So how do you assess if someone has hypotension? You do blood pressure. So that's why it's ABCs for a patient with a pulse, right? So ABCs are airway. Do they need, do they need oxygen or something? Or is their airway open, right? Is it obstructed or not? And then B for breathing. Are they actually breathing well? And do they need to have have oxygen administered, right? And if they're not breathing, what ABG imbalance does that put them at risk for? If they're not breathing. No? So if they're not breathing, the respiratory rate is low, right? They are hypoventilating. That is respiratory acidosis, right? So then the C, ABCs, the C is circulation, right? That's where you're assessing the blood pressure, right? And that's where when you do nurse interventions, that should be the last thing you fill out because everything else is pretty much a nurse intervention also. Assess for palpitations, right? Assess for chest pain, assess for shortness of breath. But we're trying to slim it down. There's already a lot of information. Okay. All right, let's move on to this AI stuff here. Let's download that just in case somebody wants that in the future. Let's clear all this stuff. All right, next one. What is this? Select or apply. Which might a patient with a VTAC exhibit? What symptoms? All right, so we got chest pain. Why is I went away from highlighter? All right, that's actually me. Hold on, there we go. All right, so that's chest pain, right? And they got shortness of breath, hypertension, no, and then confusion, right? And that could be, these could be reworded any other way, right? What's another way to say confusion? Altered. What's another way? Comatose. Another way? Stupor, somnolent, right? They're sleepy. These are all ways to say they are confused in some sort, right? So on the test, it's, yes, we want you to identify things, but that identification level question is just, can I reiterate what was on the PowerPoint slide, right? But what's in real life is the patient's not going to complain of all those things, right? They're not going to say, like I have poor urine output right now. And poor urine output is a sign of poor cardiac output, but that's not something they really assess. So you'd have to assess that later, right? And it takes you an hour to assess that, but it doesn't take you an hour to assess chest pain or shortness of breath, right? That's why we kind of put those higher up on the list. All right, next one. Let's look how it apply for potential causes of ventricular rhythms. Good. H's and T's, hypoxemia, hypovolemia. Hypoclemia, is hyperclemia on there? It is, right? So these are H's and T's, right? So you should know you should know the H's and T's that we've talked about, right? So things like toxins, we really haven't talked about overdoses besides overdosing on beta blockers, calcium blockers, and glyburide, right? What is glyburide? Good, your sulfonylureas, right? So those are reversal agents, right? So maybe I should put this on a like a whiteboard. Might make more sense. Then we can save. They might look a little better later. Let's put new share for whiteboard. You can stop me. If it's like, no, I know that perfectly well. Stop telling me about this, right? So we got like over OD, right? There's an offshoot of H's and T's, right? For toxins, right? I mean, we could first talk about H's and T's, but as far as like ODs, things you can overdose that we're talking about are you can overdose on beta blockers. You can overdose on what else? Calcium channel blockers and digoxin, good. And what else? Opiates, good. I didn't leave enough space. Benzos. And then sulfonylureas, right? In the corner there. And then we have, let's put the antidote in green, right? So beta blockers are, what's the antidote for that? Glucagon. What's the antidote for calcium blockers? Same thing, digoxin. Digibine's a brand name. So what's the generic name that the NCLEX and myself will test you on? Digoxin immune fab. Again, I should have planned this out better. Immune fab. Okay. And then opiates. Naloxone. And benzos.
That's R, right? I can see, I can.
Romazicon.
I'm like, in my head, I know.
So I would rewrite this, but you can see the Z kind of lines up there, right? It's the only one that has a Z in it. And then sulfonylureas, what are those? Mhm. It's the sulfonylureas are sulfate based, and they have and you want to be alert to sulfate allergies. But if they take too much of it, they get what symptoms? Hypoglycemia, right? And therefore you want to reverse that with what medication? Yes, D50, but
Alert later.
good. So we're thinking hypoglycemia, which is you can kind of put under ODs as a what's the word? As a transition into that. But what's what's a specific medication you give for sulfonylureas? There's an echo in here. So she just said D50. So D50, but sulfonylureas itself, it's a medication that suppresses the whole GI tract. It vasoconstricts the whole GI tract, and it shuts down the GI tract. It inhibits all the things, including insulin, which is what sulfonylureas do, is they promote insulin secretion. Starts with a vowel, not a V. So I should left more room, but it's octreotide. Octreotide. It's on, I think it's on diabetes like 3 times. So octreotide is for sulfonylureas, right? So yeah, I should have, now I feel upset at myself that I didn't plan this out as far as making this look pretty. But either way, if I was making a chart out of this, I would then say that it is, let's save this for whoever wants to see this again. That's because that's an ugly drawing. Let's clear all that stuff. So let's recap here on so let's put notes on below. All right, so let's insert a table. This make it look a little pretty. I don't know why I always try to draw when I can't draw. Let's go to a table. Right there it is. All right, so let's make it this biggie. Okay, so I put down agent, right? Overdoses is the name of this table. I don't know why is there a huge space there. Anyways, agents and then examples, right? You could say example, overdose. Examples of it and reversal agents, right? And other notes, right? So to recap, so we're talking about EKGs. Let's do EKG stuff first. That'd be beta blockers, right? What's an example of a beta blocker? Yes, ends in LOL, right? E.g. man-babe. So it's not just man-babe ones, it's also labetalol and carvedilol. All right. And reversal agent for beta blockers are glucagon, right? And other notes is, it can, I could probably put symptoms, probably be nice to put here. I probably want to put this before reversal agent so I know what to do. Okay, so symptoms, what are symptoms of beta blocker overdose? Laughing out loud's not there. So dysrhythmias or EKG changes is a good answer, but what EKG changes?
One of the reasons your AP block, it depends on if the person already has prior history of it. An AP block and.
Nope, not the QT.
Your PR.
Good. So you can put down EKG changes, right? There's a prolonged PR. So usually I'd like to make sure it's nice and good arrow. Increased, right? And we'll probably use decreased somewhere. Okay, what's it many times? So it's increased PR interval, right? And then what else? What's decreased on the EKG? Good, decreased heart rate, right? So you can put down here, you're going to have, oops, low cardiac output, right? Let's use this one and this guy here, low cardiac output. Right, and that's chest pain, shortness of breath, low BP, and what's the last one? Confusion, right? Low CPK, no. All right, so they got low cardiac output, they have EKG changes, and what else? What else would be someone that's too many beta blockers? Anything? Oh, mm-hmm. All right, we'll come back to it. And then what else is in what you could possibly OD on? Calcium channel blockers, right? And then what are some examples? And indipine, right? This is usually for the DHP ones, okay? And indipine, so therefore you're going to have this, and you can put some examples here, right? And reversal agent is glucagon, so that's nice. Okay, it's the same one. And what about symptoms? Same. All right, next. All right, sorry, it's going to be, I'm thinking of diltiazem. So let's pause real quick. So EKG changes, you're going to have low cardiac output. That's going to be the same for sure. Let's actually put that at the top there. Okay. Good, good. Very good. So you can have reflex tachycardia, right? So you have increased heart rate, right? Reflexive tachycardia if you overdose on these guys. Okay. And then you have the symptoms of calcium channel blockers. So you can add them there. Okay. That is going to be extreme, or just remind yourself what are calcium channel blocker side effects, right? And then what are the other agents we can OD on for this exam? Well, one more EKG one. Good. Digoxin, which is example, DIG, right? And then reversal agent is and then the side effects. Good. So you got nausea, vomiting, diarrhea, and we have yellow halos. Right? And the EKG changes are going to be low heart rate, right? And if you don't know what digoxin is, you can put some more information there about some details on digoxin, right? And then some other agents. So we talked about sulfonylureas, but what about these ones here? What are some other two agents we talked about for ABG? So benzos, right? And what's the other one? Opiates. And then some examples. What are some examples of opiates? Fentanyl is a generic name. Good. I heard a lot of brand names and street names. Morphine, right? What else? All right, so hydromorphone is Dilaudid, right? And you can put some other examples there. What about benzos? What are some examples of benzos? So they end in pam usually, right? So temazepam, lorazepam, diazepam. There's a few other ones out there like that don't, but what else? Reversal agents. How do you reverse benzos? That's the romazicon, right? So you can just highlight that, romazicon. And then the opiates, what do you reverse them with? Naloxone. Okay. And then what are the symptoms of benzos overdose? Not so much low heart rate. They're going to be you're going to hypotensive with all sedative medications, but it's going to suppress respirations. That's the key. Right? Decrease respirations. So that leads to what kind of ABG imbalance? Good. Okay, the decreased respiratory acidosis, right? And if you don't know what those symptoms are, then you can start filling them in, right? So the respiratory acidosis, they have a decreased respiratory rate, so they're not gonna be able to respond to that. So they will have an increased heart rate and to get clammy and such. So the S is gonna fire off because the respiratory rate's low and they're not getting oxygen to the body, but the S is gonna try to make them breathe faster, but they have this benzo that's stopping it, right? So you're not gonna get all of the S symptoms because of the medication stopping it. All right, and then opiates, same, right? There's a few other things in there like pinpoint pupils and stuff, but you'll learn that in message 3 with like actual overdose and poison control and all the other things there. All right, sulfonylureas we mentioned. What are the examples of sulfonylureas? Those are the ides, right? So they're glyburide, glipizide, glimepiride, right? Usually they start with a G, ide, because there's like the glutides. Don't get confused. Ide is always sulfonylureas. All right, so then reversal agent we said was octreotide, right? Octreotide. All right, symptoms of sulfonylureas, you get hypoglycemia, right? And if you don't remember hypoglycemia, you can put the you can put the symptoms there, right? So other symptoms, sulfonylureas, you can just think just side effects in general, but you don't want to, I mean, you could put them there just to refresh your memory. All right, is that good? Is that too much time on overdose stuff? All right, so something that'll apply on potential causes of ventricular rhythms, H's and T's we were going to go into, right? So we mentioned with H's and T's, and we got a tangent because we're talking about toxins as a potential overdose, right? But it's like toxins that took too much sulfonylureas, they could then have hypoglycemia, and that could lead to lethal rhythms, right? But what else? We got, let's do the next one. Pulseless VTAC. Which of the following interventions are appropriate? Pulseless VTAC right here. So pulseless is the key word here, right? If it was VTAC with a pulse, we would change gears, right? VTAC with a pulse is like every other tachycardia with a pulse. You do something specific for those guys, right? So what do? We do CPR. Do we do unsynchronized cardioversion? Good. What is synchronized cardioversion for? VTAC with a pulse, right? Administering epinephrine, is that correct? That's correct, right? CPR, epi, and shocking them, and then shocking them in an unsynchronized way. And then what about amiodarone? Yes, amiodarone is given for VTAC. Remember, it's one of our ABCD agents, but it's the one that does for both, right? It plays for both teams. All right, so then torsades. What are possible causes of torsades? Good, R on T. Low electrolyte levels, mag, potassium, and what else? What else is low? What other electrolyte can be low? Calcium. Okay, so that means high calcium is not correct, right? And then prolonged QT, does that do it, or is it prolonged PR? Which one? QT. Very good. All right, so those 3 are correct. All right, next one. What interventions are appropriate? What should you do for torsades? It's the same stuff for pulseless VTAC, except we have an extra few things we can do, right? We can give them what else? So that means that CPR, epi are correct, and unsynchronized cardioversion would be for torsades, right? But MAG is an extra thing we can do for torsades, right? And then what about amio? Can you give amio? You can. You can if it wasn't caused by prolonged QT, right? If prolonged QT caused it, amio probably not be a good choice. But if it was just low electrolytes, yes, we could, right? So amio is possible. Okay, depends on the underlying cause.
I know that amiodarone you can use for, it's like your all-purpose, right?
Mm-hmm.
But I don't think that I understand like how it works. Like everything else has very specifics on how it works. But I feel like amnio is like one of those like maybe possibly like you could like how do you know when I mean in our case right now we just need to know if you can or can't for what rhythms and I know that part of it, but I'm like, how do you make the deciding factor on when or when not to use it?
So amio is, yeah, for ventricular rhythms, it's great, and it's great catch all, because if you don't know if it's atrioventricular, like you mentioned with SVTs, sometimes they can be wide, right? Because they might have a bundle branch, or it was VTAC the whole time, right? So you don't know. So that's why we always say wide complex tachycardias are VTAC until proven otherwise. So that means amiodarone is going to be used usually. Okay. So like you're asking, like, how does amio work, or how do you know it's for ventricular rhythms? It's kind of the same question. So amiodarone, it works based on the cardiac action potential. That was the whole reason why we introduced you those things, right? So there's the cardiac action potential. And remember, K is what is going to bring this down, right? K is cold water, right? So K going, I should have done the other way. K goes outside the cell. So hold on. Got to check a box somewhere. Hold on. All right. So K is going to go outside the cell. It's going out here as well, but calcium is going in and it's balancing it. That's why we have this plateau phase. But K is going outside the cell, right? Outside the cardiac cell. It's cold water. It's going to cool it down. But there's nothing else coming in that's hot water. Like we have a hot and cold water going, right? It's warm. But if you turn off the hot water, now it's cold, and the bath temperature, the whole temperature of the cell is going to go all the way down to its resting temperature or membrane potential. Right. So what does amiodarone do? It is a K channel blocker, right? So amio will inhibits this. So what happens then is our time it takes to repolarize is prolonged, right? And then what if you have like impulses that are trying to get through? Like your VTAC like this, right? So the heart rate is going to be less. It's going to lower that heart rate because you just blocked like two of those complexes because you prolonged that refractory period. And the refractory period is measured as the QT interval. So amio, yes, prolongs the QT, right? That's how you get to the answer every time. You may just, it's just like how you get to your grandma's house who lives in Tehachapi. Like you got a good idea. I got to go up to 14 North there. I know there's an exit somewhere, you know, right over there that I know there's an exit to go take the 58 across. And then I know once I get there, maybe it's like there's only 3 exits to Tehachapi. So it's on up to the second or the third one, and I have to go up this road a little bit. So once you do that 5 times, 6 times, you're gonna know exactly which exit Mojave to take. You're gonna know exactly which exit in Tehachapi to take and exactly which road she's on in Tehachapi, right? So that's the whole idea behind teaching. That when you teach this multiple times, the first time you do this, you're like, I don't know which channel blocks, I don't know which one it does. But there was 3 steps here, right? Once you know how the layout is, or I know if to go north or something, that's the idea behind teaching, is you're gonna form more pathways, you're going to form more synapses, and you're going to be able to, you know, be confident with this information, right? I'm not smart because I can spout this out. I've just done it so many times. I've done that. I've driven it many times, right? So that's you know, when you drive it more often. I give a visit grandma since she died 20 years ago. I don't get immortal, but then when you go back up to grandma's house 20 years later, you're going to have some recollection, right? But if you go there every 3 months, you're going to be much better at it, right? So that's the idea behind teaching stuff. So when I usually ask people like, are you doing study groups? Like, no, I don't have time. I can't find it. It's like when you teach it, that's going to be the best way to solidify this information. Okay. So that's what it's, because otherwise if I just memorize, oh, it's a K channel blocker, oh, it's a K channel agonist, or did it prolong the QT or did it not prolong the QT? Well, if you know how it works, well, of course it prolongs the QT, right? This is my EKG right here underneath, right? So I got the P wave, and then this is my ventricular contraction, right? And then I got repolarization. This is repolarization right here. So that is my QT interval. Let's do a different color. Let's do this guy, right? So this is my QT interval, brown, I guess, right? So that's my QT right there. So the QT gets prolonged with amio, right? I mean, yeah, you don't have the time to, I'm not going to test you on which, you know, what's the member potential going to be and which exact channels is it working on and all those kind of things. But you need to take away from all this that the QT gets prolonged, right? And it's for ventricular rhythms. and not for and it can be used for AV node blocks as well. AV node, it suppresses the AV node as well because it's working through the whole heart. It's not just doesn't just like just touch the ventricles. It goes throughout the whole heart. It affects atria as well, right? So the atrial muscle is also affected by our amiodarone. Okay, so yeah, so when I teach you in theory, it's the idea is that you know how to get there to the answer. You may not be great at all the pathways, but the pathways at least are, are written, right? There's like when they designed Disneyland and they didn't create trails, they let the people walk to those areas on grass, and they developed the pathways after that, right? So the pathways are developed by footsteps. So you have to teach it every single time on how to get to the right answer, right? If you just memorize, like in Disneyland, it's over there somewhere, right? But do you know exactly how to get there? What are all the pathways to get there to the right answer, to the right destination, right? And you want to do that before the test. You want to practice getting to the wrong answer a couple times before the test. You want to try to get the right answer as much as possible. All right, enough of that. Okay, cool. All right, so let's download this. Let's clear all this stuff, and we're on this one, I believe. All right, so prolonged QT, right? And then this one, interventions for torsades, we did that. All right, what are some reversible causes? What are some H's and T's? They're just saying, what are your H's and T's, right? So a lot of these are, it makes sense. They're like SNS stuff. When your pH is too low, when your CO2 is too high, that's really your pH is too low. When you have too much potassium, or sorry, that's not really SNS, I'm getting off topic. When your oxygen is way too low, that's going to be a problem, right? So oxygen too low, that's hypoxia. And this can be as a question, when you're writing a question, this is, if I just say, what are H's and T's, and you have to select from a list, that's a low level question. So 15 questions are like this, where you just like, oh, I memorized H's and T's. Oh, there's hypoxia. There it is. That's the right answer, right? But a next level question is, you're going to say, what are examples of hypoxia? So what are some examples of hypoxia? So you got low O2. So SpO2 less than 88%, right? So that would be a correct answer as well, right? Or I have a PO2 less than 80, right? I have someone that is like maybe for the final, really, when we talk about hypoxia for respiratory, they're breathing fast, they have orthopnea, they have some late cyanosis, they're cyanotic, and they're breathing fast. And before they rested, before they had a lethal rhythm, it's like, well, they had all these symptoms of hypoxia. Which do you think of the H's and T's? Thinking about the H's and T's, which one do you think it is, right? Well, with all those symptoms there, that's all hypoxia. Hypoxia would be the correct answer, right? Tamponade. So tamponade we didn't really talk about, and we might touch base on it with cardiac, with pericarditis and such, but that's not really for this test. But tamponade is one of the T's. And then thrombosis. So we kind of mentioned thrombosis a little bit. We'll talk more about it with on Monday with like a coronary thrombosis. But we talked about what kind of thrombosis. We talked about PE and we talked about strokes, right? And PE, I think we mentioned some of the symptoms of PE, maybe not, but we'll talk about them with cardiac as well. But right now, I can't really test you on the stroke symptoms, so I can't. But that'd be a next level question. Is like it has the stroke symptoms instead of just saying from stroke, right? And then hyperthermia. So I think it's hypothermia, right? Anyways, next one. Let's talk about apply for VFib. Which of the following actions should be taken? So immediate defib, which is also known as unsynchronized DCCV, direct current cardioversion, right? And then CPR? Yes, right? What about epinephrine? Yes. What about amiodarone? Yes, it's there too. So really, pulses, VTAC, and VFib have the same treatment. There's no difference. So if you wrote a table, then you'd realize what's different? Nothing. There is no difference. Pulses, VTAC, and VFib are exactly the same. Yes. All the lethal rhythms except for PA asystole are on their own thing. It's just CPR, epi, and thoughts and prayers. There's nothing else you can do for those guys except for reverse the H's and T's. If you know you try to go through the H's and T's, all right, when someone's coded in the hospital, let's say, well, are they hypoxic? Well, we usually put a tube and help them breathe. And whether they have hydrogen ion excess, usually give bicarb. It's not the right thing to do, give bicarb, but we still give bicarb, right? Do they have hyperkalemia? So we'll give calcium chloride, for hyperkalemia, right? I should have asked you because we did tell you what the treatment for hyperkalemia is. What? Calcium chloride / calcium gluconate, right? Which one's stronger? Calcium chloride. Which one's the vesicant? Calcium chloride or calcium gluconate? True, it has sugar in it, and that's a good distractor. But calcium chloride is much more concentrated. All right, calcium chloride. Let's put a little note on calcium chloride. All right, versus calcium gluconate. Luke, right? So what you can say, like, which one is stronger? All right, calcium chloride. Which one's a vesicant? Calcium chloride, right? Which one is like found on the crash cart? It's calcium chloride. You can think of CC for calcium. It's a crash cart. It's the one you're going to use in emergency. Also, you can think of Cs for central lines, like CVCs, central venous catheters. They should be administered via central line if possible. All right, someone's coding, you're like, oh no, we need a central line. All right, this is like more after the fact. All right, so I think that's, I forget what we're talking about. Out of the way, go back into the last question. All right, so PEA. What interventions do you do for PEA? CPR and epi. That's it, right? And revert. That's what we're talking about. Reversing the H's and T's, right? So it's that is the treatment for all of lethal rhythms. Reverse H's and T's. Except there's one where you can do extra stuff for. Which lethal rhythm can you do extra stuff to say, oh, they have this lethal rhythm, I can do this too. Torsades has other stuff, right? You can add what? What other treatments can you add? You can do MAG, right? And what else? You can, what gets like an acute situation, not much. MAG is the additional thing you would do. But if they have torsades, you would say, let's stop the QT prolonging drugs, right? Let's look at the electrolytes, right? Are the calcium, MAG, or phos low? And the MAG we fixed, hopefully, but those are the additional things you can do. Okay. All right. Do you feel good on ventricular rhythm? So what do you want to do next? On what? Is what do students have the most trouble with is and it's critical thinking level questions. That's the hardest because you're used to, especially from first semester, you're used to like, Foley catheters, what kind of procedure? Sterile, right? So you can see that in the book, sterile, and you can then do it right there, right? A next level question would be identify from this list what would be done for a Foley catheter patient insertion, right? You'd have to select the sterile gloves, right? Try to give another critical thinking question you could ask about Foley catheters, but that's the idea. This stuff, it's much easier to ask critical thinking questions because it's not very clear. Like there's 5 different names for adrenaline: catecholamines, norepinephrine, epinephrine, dopamine. There's all kinds of different things you can say in its place, right? And then you could say the results of those things, right? So that's the biggest thing is the difficulty with the exams from this point on, is that they're critical thinking level. And again, you don't, once you get lost in the details of all the why is to help you understand the items that you have to know for the test, right? You have to know AFib has these consequences, or AFib has this, right? Or this medication that works this way, and therefore you have these side effects you have to know. You still have to know the side effects. I don't have to tell you how they got the side effects, but knowing the side effects and the reason why is going to help you the most and going to make you memorize it the best, right? Otherwise, it's just a list of 400 things for you to memorize for Monday. Usual activity. What do you want questions on? Or do you want to do more questions, or do you want to do? We can tell it to make higher level questions. On what though?
I think I feel good about EKGs. I think my hardest thing is the diabetic medications. It's just the diabetic medications, and then the, I don't, the, what is it, food percentages or protein percentages?
Mhm.
Making that correlate together for your.
All right, so let's grab this stuff.
that percentage in your swap outs.
All right, so write, doing 10 questions again, 10 hard, spicy, extra critical thinking level questions. On the following, make them all SATA level questions. SATA level questions, and then, right, where more than one response can be correct. Give 6 or 5 possible choices, right? Anything else you want for them? Put some lab values and vital signs, histories, and other cool stuff in there, right? Base it off. That's be that long. Let's go down there. There we go. So let's go ahead and copy them over here when they're done. Let's insert horizontal line, and let's make this one diabetes questions, meds, and treatment questions. Let's let it finish. We're on number 6 right now. All right, so questions 1 through 10. I don't like how it gives you the title, then you kind of know what's going on, but let's go with it. All right, so why is E always indented? That's going to frustrate me. Either way, we got A1C and diabetes management. Okay, so what is the option here? Let's answer this first one. So I didn't make these nursing level. These are more provider level, like what medication are you going to prescribe? That's not our job. Our job is to know what's, they're on this medication. What do I do about it? What are the side effects? So but we'll try to work through this. Like this question would not be a question we'd ask, like increase the amount of insulin they're getting every day or do this or that, right? But they're type 2 diabetic with is 55 years old. That's important because usually type 1 diabetics are diagnosed early. But what the A1C is 8.2%. Is that good? No, that's too high. So A1C, what are the things for A1C? That's 7% when diabetic, right? When diabetic. Okay, if they have diabetes, you want your A1C less than 7, right? But what else about A1C? I think it's 6.4, isn't it? Either way, 6, that's pre-diabetes, right? Yeah, 5.4 and less, or less than 5.5 is fine, right, for a normal person. But someone has diabetes, you have less than 7%. Why don't you have less than 6%? Because that causes hypoglycemia, so it's not good, right? And then greater than 9%, greater than 9% is usually a need for insulin for a diabetic, right? You usually be on insulin at that point. All right, so increased metformin. So the routine checkup A1C is 8.2%. Is that good? No, right? So again, this question I would not be asking exactly. I wouldn't say start insulin therapy because that's for 9%. Discontinue oral hypoglycemics. That doesn't sound right, right? They need more, if anything. Usually you can be on like 3 to 4 at a time. Okay. Initiate lifestyle and dietary changes. A little bit late, but we can evaluate that, see how they're doing. No change is incorrect. Increase metformin dosage. I guess you could, right? But that's not really our job to know whether it's increased or not. So that's my error for not specifying to AI to make them NCLEX style. All right, so the next one, let's download this. And there are all those guys. So what's next? We got a patient with type 1 diabetes, and they have frequent episodes of hypoglycemia. What causes this? Why do they have hypoglycemia? That makes sense. Inadequate would that cause hypo?
Well, I guess it depends what inadequate means, because does inadequate mean that they're giving themselves too much or too little?
Well, it's still too little. If you don't have enough insulin, you're going to have hyperglycemia, right? Because insulin is going to lower your sugar. Does that make sense?
Inadequate insulin dose, so if they're giving themselves too much, then they're gonna have hypoglycemia.
Well, that'd be excessive, right? So inadequate versus excessive. Inadequate would mean not enough. So overconsumption of high glycemic food index foods.
They skipping meals and then incorrect blood glucose monitoring.
Mm-hmm. Yeah, if you're not monitoring the glucose, you're going to have a risk for hypoglycemia. They just go say, I just exercise every morning, right? It's like you have to check your sugar, right? So these are some exercise rules. So what are your exercise rules for diabetes? Check your sugar before you exercise. What else? It's just take your insulin, but don't exercise at the peak times of that insulin, right? So that being said, if they're on like a long-acting insulin, when should they exercise? They're getting glargine in the morning, or degludec, or glulisine in the morning. When should they exercise? No,
After 6 hours.
no, good. There is no peak, right? For these ones, for your long-acting insulins, there's no peak, right?
Yeah,
All right. So, but yeah, if they took regular insulin, right, then the peak is about 2 to 4 hours. So they shouldn't be exercising at that point, right? What else about exercise? Yeah, don't work out the muscle that you put the insulin into. Okay. What else about exercise rules? You should eat, right? Well, technically you only need to eat if your sugar's under 100, right? If sugar's low, you should get some food in your body, and then do you just run out the door, or no, you should check your sugar again, right? And then by the same token, what if the sugar's high? Yeah, so if blood glucose is greater than 250, they should not exercise at that point. And they might have some kind of management strategy at home where they take some more insulin if the sugar's high, but yeah, they probably should not exercise that morning, because exercise will raise your sugar too. Okay, that's the SNS response. So your movement, blood glucose goes up, right? So what else on exercise? So it's aerobic exercise, good. And how much aerobic exercise? It's per week, how much is it? So if it's 30 minutes a day times 7, it's 210 minutes per week, right? So how much what do we want? Is 150 minutes. Okay, so 150 minutes per week is all we need, right? So the light math might be that is this 150 minutes or not, right? And then what else? They have to be walking. They can use their Apple Watch, right? To make sure they get how many steps per day? At least 10,000 steps, right? And then to avoid injury, what should they do? Yeah, the partner's not going to help them run. But to have a partner, the partner piece is what? What's the reason to have a partner? Is for safety in case you do get hypoglycemic, right? Or you get hyperglycemic and you start getting dizzy and you have hyperglycemia symptoms, right? And then the medical alert is if you don't have a friend, right? You're not good at making friends. And then if you fall down in the woods, like, well, okay, so this guy's diabetic, let's do something, right? And then that goes down to the next step, like, what do I do for hypoglycemia, right? But yeah, it's also to avoid injury would be like the shoes, right? Make sure your shoes are well fitting, right? And this is a good segue for foot stuff, right? So making sure all the feet are taken care of, right? Not only for exercise, but also for just regular foot care, right? So I'm not writing these things down, but are you okay with me not writing them down? Okay. So yeah, so foot care stuff. What kind of foot stuff do you do? Don't cut what? Don't cut your feet? You don't cut your feet either. That's not good. You can get sores that can be cut, can develop from those cuts, right? And how you know that you have those cuts? So you just go to the podiatrist in a year? Yeah, you got to check it. You check your feet every day for those cuts, for said cuts, right? So who do you get to check your cuts? Usually the same friend that goes out exercising with you, or you get your spouse or someone else to check your cuts daily, right? And they're checking if they find an ingrown toenail, they say, I'll be right back. I got a nail in the garage. Yeah, perfect nail, right? And I got a poop knife over here. I'll be right back, right? So they need to get that professionally fixed, their ingrown toenails, right? And then what about lotion? What's the lotion story? Yeah, no lotion between the toes, right? But they can lotion the rest, okay? And then what about like jacuzzis? Yeah, jacuzzi is not a great idea, right? Because they have neuropathies. They can't feel if it's hot or not. Same thing for a bath, right? Which is just a jacuzzi on a budget, right? You can get a straw. I got jacuzzi bubbles. Anyways, we have what else? Other feet stuff. Shoes had to be good, and that's kind of the same thing with exercise. Had to be leather. Like breathable, you mean? I guess. With leather, it's like maybe a cowboy. Yeah, they're just well fitting and yeah, they're probably breathable. They also, yeah, shoes are need to be in the house also, right? You can't be wearing your socks around the house, even though they're tight socks and your feet are lotioned up underneath those socks and there's no ingrown toenails under those socks, they still can't be socks, right? Or socks on in the house. What's that? There's diabetic socks too. Yeah. Anything else feet wise? All right. So yeah, so those are good SATA questions. Those are easy SATA questions to ask. Like which one of these shows that your patient understands, right? Which one of these are they doing correctly? Which one of these should be taught to the diabetic patient, right? And then same thing with exercise. All right, so that's a detour. Let's go over to the next one here. All right, so diabetic ketoacidosis identification. Where's my cursor at? There we go. All right, so DK identification. What do we do with this one? They got rapid breathing. They're confused. They have fruit breath. And which of the following lab values would you expect? Blood glucose higher than 250 is diabetes, right? So greater than 250. So C, pH less than 730, right, is DKA. K of 5.5, are they hyperkalemic? Yes, they are hyperkalemic. That's correct. What about bicarb of 15? Is less than 22 alkalotic or acidotic? That's acidotic, right? So in diabetic ketoacidosis, are they acidotic? Yes. So all of these are correct. And then we got E over here. It's special formatting here. Let's try to get this make more sense here. All right, so E, is E correct? So blood glucose of 100, no, that's too low. It has to be what? It has to be greater than 250, okay, for you to really have DK. All right, any questions on that? And then I'll give you the normal values for pretty much everything except for ABGs. So ABGs, you're expected to know if it's low or high, okay? So I made that change so that you're more prepared for not more prepared, but it's good that you know the values because in real life, yes, all the values are there, but you don't want to be, someone says, hey, the K is 5.2, and you freeze, like, hold please, let me look in the computer. Oh, that's low, or that's high, or that's normal. You do want to know where those are at. Okay. So like electrolytes, I would say are pretty important as well. All right, so let's clear these out. Yeah, and then, yeah, the same thing is with all the other instructors. Are they all putting all the normal values? I don't know just yet, but that's the, I think that we're preparing for an NCLEX style question would look like. All right, so then insulin therapy in a hospitalized patient. Hospitalized patient has type 2 diabetes and a sugar of 250. Is that good? No, that's too high, right? It should be less than what? Just think about when you give sliding scale coverage to the hospital. It should be less than 150, less than 180. It depends, but definitely less than 200. Okay, so 250. What should happen if the sugar's high? Sliding scale, if it's not already there, yes, definitely put some sliding scale insulin. That way, every 4 hours, every 6 hours, we can check the sugar. If it's high, we give them correctional insulin. And then correctional insulin is your fast or short-acting insulins, right? Monitor blood glucose without intervention. Okay. Increase dietary intake. Probably not right now. They still need calories to fight their acute infection, but we want to increase at this point. We probably want to control their sugar as well. Basal bolus insulin therapy. What is basal insulin? So basal insulin is your long-acting insulin, right? It brings down your sugar by like 5% or 10% or 20% based on how much they give them. Well, you gotta get started, right? If you give it now, then it will then come down, hopefully, and over the next 24 hours, it'll be lower, right? At onset, it's 30 minutes, right, to an hour for your basal insulins. So you start it now, then 30 minutes to an hour, you're gonna reduce your sugar by about 10% or however much was ordered. So basal insulin is a good idea. So this is like what does a hospital patient's insulin therapy look like? They can go just from sliding scale insulin to like mealtime, like the biggest meals, they'll give like 10 units and 10 units, right? And then also we have basal insulin. Okay. Yeah, so this is just plain old hyperglycemia. So DK and HHS have the symptoms of hyperglycemia. So you can copy and paste everything you know about hyperglycemia into DK and HHS. Those things that checks out. But then DK, HHS have their own differences, right? So how you know this patient's in DK, we'd have to assess, do they have ketones? Is their anion gap elevated? Do they have a pH that's less than 730? That would be, and then the sugar is not just 250, the sugar is 250 with signs of DKA. And that's DK then. That's now DK. It's just the sugar is getting high. What should happen? They should be on insulin. They should be, basically should be on insulin. And oral hypoglycemics, if they can eat and they can swallow, yes, you can add those agents. They might add like metformin or something. Okay. All right, next one. For diabetic patient on an exercise regimen, what should be advised? Exercise under supervision. Check sugar before and after. Do we need to check it after? It's not going to hurt. Avoid carb intake before exercise. Well, it depends. I mean, they should have, we didn't mention they should have snacks with them, right? They should have some fast acting sugars to prevent hypoglycemia, right? So what are some examples of that? Lifesavers, right? What should they have with them when they go running? They should have glucose tabs. They should have something with them available to fix their sugar. Avoid carbs before exercise. It's really only if the sugar is great, right? But usually you do want to have something like you would normally. All right, exercise during peak insulin action? No. Limit fluid intake during exercise? No. So they should be doing that. Exercise under supervision. I mean, what does supervision mean? All right, having a partner is appropriate. All right, next one, patient with diabetes and CKD. So that's, when you think diabetes, CKD, it's very, very common for diabetic to have CKD. The other CKD question they could ask you is metformin. So metformin is, their patients has CKD and metformin. What considerations? Continue metformin? No, we should not continue metformin. What about discontinue metformin? Yes, increase dose because it doesn't work as good. No. Monitor renal function more frequently? and theoretically, but like the best answer, if it was just 4 options, would be B, switch to insulin therapy. Probably if they need, thank you, if they need to have a, if their sugar is still high, yes, they might need to be on insulin coverage at home. Okay. Next one, let's scroll down. Let's save this real quick. There. All right, dietary management. So what do you do with diabetes and diet? Recommendations for diabetic diet. High protein, low carbs. That works. Okay, what about increased intake of processed foods? Nope, avoid all fats. Not all fats. There's low fat diets and very low fat diets. The key is saturated fats, right? Saturated less than 7%. Okay, protein is how much protein? About 1 gram per kilo protein, so high protein's fine. Okay, and then incorporation of whole grains and legumes. What's a legume? Yeah, lentils, right? So that's good. Strict calorie counting without regard to food quality. No, food quality needs to be, that needs to be important. That needs to be high quality foods. The less processed, the better. Okay. All right. OGTT in pregnancy. That's really for our OB class. So we'll worry about that later. A1C and type 1-2 diabetics. Patients at A1C and 9.5. Is that good? No. Which of the following strategies should be considered? So they need insulin after 9.9%, enhanced lifestyle modifications, sure, right? Increased dose of existing oral hypoglycemics. Maybe you should probably add some more stuff. Add a GLP-1 receptor antagonist or agonist. Okay, they're going to add some oral hypoglycemics. Start metformin if not already. Yeah, usually metformin is always in everybody. So yeah, again, this is more of a prescribing thing. So we're not going to tell you like which one do you do next. What's the order that you should add the oral diabetic agents? Because the American Diabetes Association, they have a specific order. Start everybody on this first, which is metformin. And then second, start this one. Third, start this one. That doesn't work, start this one. But that's not your job to know the right order, right? Your job is to know they could be on all 5, right? Or all 8 categories. They probably would not be on all 8 categories because there's some overlap, right? Like meglitinides are an alternative to sulfonylureas, right? So there are some alternatives in there, right? And TZDs we don't use at all. So yeah, your goal is to know, you have to know all of them, unfortunately. You have to know they could be on this medication and therefore what are the side effects, right? Like which ones cause MACE. So your sulfonylureas and the meglitinides, and then also the TZDs, which we don't use anymore, right? The thiazolidinediones. Well, I have to because it's still possible, but I'm not going to test you as much as I will on the new medications because you're going to see those more often.
Okay.
All right, so those guys, and then what else? Sorry, those are the only MACE ones. And then you can look at like what causes weight gain, right? So the big one is insulin. So when you have more insulin, you're going to have more weight gain because insulin puts sugar into the cells. It also puts fats into the adipose and makes you gain weight, right? Puts the free fatty acids into this for storage. So we have 2 medications that are going to promote insulin secretion. They're secretagogues, right? And that's your sulfonylureas and meglitinides, right? So they cause significant weight gain, right? And also TZDs do too. That's also why they're not good. They're no bueno. Okay. So you might think, well, what about all secretagogues make you gain weight? Well, the other ones promote insulin function, but they also decrease GI motility, which helps them lose weight actually. Okay. So you think of weight loss. So what are some weight loss drugs out there? Ozempic counts because it's one of our antidiabetics, right? But we can't just say on brand names. So what are they? So Ozempic and which is semaglutide, the glutide ones with the booties are Kim Kardashian booties and other booties. So yeah, so those 2 on the same slide. We have the GLP-1 RAs. And we have the SGLT2s are best one at losing weight, SGLT2 inhibitors, right? Those end in what? Those will have the same suffix of. Yep. Yeah, they end in flosin, right? So those are going to make you pee a lot. Okay, and diurese a lot. All right, GLP-1 receptor antagonists and the other guys are the DPP4s, 4 inhibitors, right? So those are the ones that make you lose weight, right? Yeah, that's kind of why I explained how they work, because then otherwise it's just a list of, it's just a thing of symptoms and side effects and such, right? Or try not to be a Davis drug guide to give you a whole list of all the things, right? Because the Davis drug guide reports every single side effect that's been reported ever on that drug, right? It doesn't really categorize it into like what's the most important and most common. Weight loss. These are all weight loss drugs, right? All right, so anything else categorically you can think between them? Okay, so yeah, so that's the idea with our anti-diabetic agents. Save this, maybe that's discernible later. All right, so then what do we got here? Last question, right? So diabetic patient has an LDL, and again, you don't know about LDLs technically yet. So we just say they have a lot of fats, and what should they do? Yeah, that's not going to be a question we would ask right now. That's going to be more for Monday when we talk about different anti-lipid drugs. Okay, and just a spoiler, statins are usually for everybody. All right, so yeah, so we'll talk about that another time. All right, so what else do you want to go over?
I think the diabetic medication is definitely something that I'm gonna have to cram tonight, tomorrow. Yeah. I think those are the ones that I don't know. And it's not that I think they're just all very close together. So sometimes remembering and the names are all close together.
Yeah, all the diabetes medications you have a G in it somewhere.
Yeah. That's my big thing is that.
Right. Any other comments, questions? We're all good?
For central lines, are we just gonna have like, is it gonna be more picture based? Like, what is this or what is
Yeah, there will
that?
be pictures. So central lines are going to be your, know what the indications are for them, how long they last, and know like what the indications will also kind of overlaps with like vesicants, right? Know how to what to do with someone that does have a vesicant reaction. What are some examples of vesicants, like the ones that we've gone over, right? We're not going to test you like on random medications, but we're most kind of usually test you on the medications for that unit that we've been looking at. Right? And what else? And then like the nursing management of it is like the dressing, right? Dressing changes and also what else? And kind of to prevent eclampsia and then the complications of a central line. If you put a central line in, you need to get an X-ray, right? Then also the removal of the central line. What do you have to make sure you have to do for that, right? And then for when they have the central line in place, in between that insertion and removal, you have to know that they could be at risk for eclampsies, right? And if they have eclampsia, how do you know they have eclampsia? And then also, how can we prevent that? What do we do in the meantime to prevent them from getting eclampsies? Right?
And the metabolic, the ABGs, some of them kind of different.
For ABGs, yeah. So it's similar as that you have to identify and interpret the ABG and then and figure out like what EKG would go with it or what diabetic complication might go with it. What is, and then the ABG themselves, are they breathing fast or breathing slow with this ABG, right? And then what's the treatment for that? Like we know how to treat ketones. We know that the treatment should be, FIE. We know with hyperkalemia, there's treatment for hyperkalemia. Hyperkalemia causes what ABG imbalance? Causes metabolic acidosis, right? So we know we can give hyperkalemia treatment, which is what? So DKA is, yes, has high potassium, but there's a little caveat there. Yes, it's high potassium, but they have a whole body low potassium, so don't really lower the potassium more. When you give insulin, that's going to lower potassium. So just spoiler, the answer to the previous question, what how you treat hyperkalemia is insulin. But like in DKA, they have hyperkalemia, but we need to give insulin because insulin is going to stop them from making ketones. That's the underlying problem. Yeah, and that will lower your potassium more. So we have to be cautious with those with DK patients. We have to actually replace potassium on them. All right. So yeah, so ABGs are, what are the causes and treatments. Okay, and then symptoms, yeah, you're gonna get symptoms, and that's kind of goes back to SNS, right? If they have hypoxia, they're breathing fast, they could be breathing too fast, and they could have respiratory what? They're breathing too fast. Respiratory alkalosis, right? And that would be the symptom. They're breathing way too fast because they have hypoxia, for instance, right? And then there's overlap. Everything's not just black and white. You can't say respiratory alkalosis is always hypoxia because hypoxia can also be respiratory acidosis, but it's severe hypoxia, right? So the hypoxia to the point where you're not just whole, general body hypoxia, it's just hypoxia in the brain is to the point where it can't send the signal out to make you breathe. So now if you can't breathe, you have respiratory what? Acidosis, right? So yeah, hypoxia is in both categories. So you just have to draw the line somewhere. Right? You can't just say pneumonia always causes respiratory alkalosis. Well,
That they presents with, or it may say like initially your patient presented with, agitation and a low two-stat with respiration exap.
You'll see the respirations are fast, and in the stem it'll be there. And also there's some case studies there. Have you done case studies before? Or is it you have to tab through the chart? I don't want someone's gonna probably guarantee you come up to you. He's like, I didn't know there's more information on the question. I know I could click all the tabs that has the ABG, it has the vital signs, it has all the things there. Trying to give you all the clues so you can answer the question. Oh, you want to lecture before the test? We got a vote in the room for lecture before the test. No, I'm not gonna do that to you. I would never want to do that myself. So.
Can we go over like uncompensated, partially compensated? So I think that like I had yesterday I think I have it figured out now. Well, I did well on the ABG test, so I guess I do have it figured out now. But is it just, I guess the part that was confusing me is when we went through it with you were saying that like it was on the acidotic side of normal or the alkalotic side of normal. But that doesn't really matter in the sense of whether it's compensated or not because of the fact that it's just based on if that number is within normal range, it means that it has not moved to change the other number, right?
So it's based on pH, right? The pH is normal, then it's fully compensated, right? If the pH is abnormal, it's one or the other, right? So you have to ask, look at the other value. So you determine hopefully that, what caused the problem. Is it metabolic or respiratory acidosis or alkalosis, right? So you look at the other number. Okay, so the other number, if it's normal, right? Or it is abnormal or outside the range. This flowchart's not perfect, but we have what's the other number, right? Because the pH is so the pH is abnormal, so we know we don't have full compensation, right? So this is always full compensation, or it's just a normal ABG, right? But otherwise, pH abnormal, and you got to look at the other number. Look at other number, right? And if that other number is normal, it's what? It's uncompensated. End of story. Okay. If that other number is abnormal, it's partially compensated. right? That's it. There's no other
Yeah.
way to look at it. So the big thing is, it can get tricky with, I guess, I'm not going to have you write a question like, is it fully compensated or normal, right? That's not, whoops, undo this one, highlighter, right? But that doesn't look like a highlighter. Hold on. Let's just underline it, I guess. Right, but pH normal, right? And usually the other normals the other values are also abnormal. Both values are abnormal because the spectrum of things it goes from abnormal values, or let's do this way. Goes from uncompensated to partially compensated to fully compensated, right? That's the progression of things. So you can think of it like where along the spectrum is it? Has it done nothing to fix the pH yet? Has it done partially something, or has it fully compensated it, right? Fully compensation is the end, but we kind of look at it first because then we're not like backtracking. It's like, oh, we're there. We've already arrived at our destination. Okay. I'm sure this can look a lot prettier in good notes. All right, so let's go ahead and save that, I guess. All right, any other questions?
For the, ASOL, the ones that are questions for you, is that something you have to purchase or?
Yeah, there's a free version. Yeah, you said and we are smarter than computers currently. So you have to realize that all it's doing is trying to please you as a human. So you have to realize we have to recognize that it might mess up on some of the questions. Even when it gives us you can ask for rationales too, right? When I go back over here to the AI, it'll tell me, I can say, hey, give me some rationales, right? And when you read the rationales, give me rationales for the first. Well, you realize the rationale might not be correct, right? So we have to be able to discern that these are correct or not. And if you have a question, of course, you can ask me, hey, it said this is correct. All right. So it'll give you the rationales in detail for all the answers. You can even feed it an NCLEX book and say, give me the questions on EKGs. I don't know if I have an EKG book on here. Where might I have a book? Let's see. I have a book over here, actually. I shared like 5 EKG books with you. Let's go to spring 2023. Let's go to over here. Let's grab this book here, exam 1 study tools from last year. And we got EKG texts here. We got like 7 books. Let's take this one, interpretation made incredibly easy. Let's download this, 10 megabytes. Let's throw it into, where's it at? There it is. All right, so let's attach that book here. All right, give me 5 questions in NCLEX style from this book. It'll do its thing, right? You can throw in our textbook and have it give you questions. You can copy the chapter and say, give me 35 questions on this content. So it'll just spit it out for you. It read the whole book in that amount of time.
Do you recommend like a certain site that you used for like style questions?
Well, before AI, I don't know. I
Yeah.
would just Google it. When I was in school, I went to all the possible sources of physical copies. I went to Barnes and Noble, I went to our library, I went to the public library, LA County Library. You can check out and have NCLEX books delivered to you, right? There's LA County Library is millions upon millions of books, and there's a lot of NCLEX books. And as long as it's an NCLEX book in the last 15 years, you should be fine. If you find something contradictory, you can ask me. See, how about questions on PVCs? Give me 4. All right, so that's the idea. I mean, you can use this as a tool to help, right? For maybe for the next deal, there's all kinds of AI things that examine notes, right? You can take a lecture, you can pop it in there, and it'll outline for you, do all kinds of things for you, whatever you need to do. You can say, make me flashcards, right? Make me a stack, make me some flashcards on this text for the chapter on atrial rhythms. You can copy those into whatever program. If there's a certain program that needs to have them like separated, like, one front and back, you can have it do that as well. Right, so it makes your flashcards in 15 seconds and then you're done. So I guess the number one would be the front, and the one would be the back, maybe, I don't know. But you got to make it design what you want it to do. Okay. All right. So any other questions, concerns? Is what to expect? Yeah. I mean, that's the purpose of this, is they can. Mhm. Yeah, so that be able to answer those kind of questions and that's what you should do in a study group as well, is just ask questions and try to teach it to each other, right? Usually the teaching to each other is going to be like up to this point, and now you're just reviewing and going over things and trying to make connections between all the content and identifying those things, right? And like spouting them out. Don't just read from your cards or from your notes. You need to be actively trying to recall the information as much as possible.
It helps that, for example, being asked a question and I can then think like, oh, okay, what's this? And then I can rationally think why it's not that.
Yeah, talking through it is going to help you clarify the information, right? And identify if something's correct or not, right? So like if you're teaching each other exercise and diabetes, you're like, well, was it before or after? I can't remember, right? I mean, I gave you that information, but sometimes you'll come across things where you don't really know if it's like if they should do one thing or the other, right? So that's the idea, is try to find those gaps in your knowledge, and because you'll come up with things. If you just read off the page, you're just going to try to read it and read it and read it, and then you don't realize that there could be other ways to ask this, right? The NCLEX can ask it differently. Usually, when I ask a question, I'm going to ask something. Do you understand this, right? Do you understand like a plant-based diet? You say plant-based diet. Where you look on the test, where's plant-based diet? It's not going to be there, nowhere, right? You have to know what a plant-based diet is, right? You have to know that. Yeah, you have to know what Mediterranean means, right? That means, was it fish, but poultry, or not fish, what should I say? Sea animals, right? It's going to have, some, olive oils, some oils that are not saturated. It has a lot of, a lot of vegetables and such. So that's the idea. Okay. Same thing with, I don't know, with like causes, for instance. So the causes are being sedentary. So we know that. So we have to recognize there's different ways to say obese. Okay. Really, that'd probably be more for the next exam where we talk about all the obesity stuff. But obesity is an important reason for diabetes. But as far as like maybe like symptoms, right? Like polyuria. How do you know someone has polyuria, right? The patient's not going to complain of polyuria. But you have to observe, polyuria, but you have to observe that, right? They peed this much over the last 24 hours. They're complaining of increased urination. Those are the things you would look for, right? So that's there's kind of investigation there too. There's kind of solving the puzzle. I usually give you like 3 to 5 clues that this is that disease process, if I want you to figure out the disease process. And am I trained to be doctors? No, I'm not trained to be doctors or providers or anything. But as a nurse, you have to recognize, as like an ER nurse or a patient on the floor, they're complaining of these symptoms. You have to know that might mean this, and you have to let the doctor know. And you have to do an SBAR report, and you have to say, this is what's going on. There's a situation. Here's the background. These are my assessment findings. And they say, okay, thank you. And they say, well, our recommendation, do you think this might be DKA because they have a pH of 720? We did an ABG, and we have the potassium was a little elevated this morning. The bicarb and the chemistry was low. So you have to know those things as a safe nurse as well, right? So the job of a doctor and a nurse are different. You both are going to see symptoms and come up with an assessment of what it is, right? But the difference is that a doctor is going to prescribe things, and they're going to give and write an order for medications. The doctor also writes the plan for the patient. They say, I want to do this, this, and this. There might be surgery, there might be other things involved. So they're going to decide on the plan, and then you're the one that has to carry out the plan, right? And to carry out the plan, you can use an LVN or a CNA to help you do that as well, right? The CNA can measure the urine output. The LVN can carry out the teaching that you've developed, right? So there's a whole spectrum there, but it is all a team effort. So does the LVN have to know about symptoms and diagnoses? No, right? You're not really diagnosing. You're assessing what's going on, and you're finding out what it is, right? And there's important diagnoses that you have to differentiate. That's called a differential diagnosis, where you figure out, is it DK or HHS? Is it hypoglycemia or hyperglycemia? Is it metabolic acidosis or metabolic alkalosis? Because the treatments are different, right? It's your license on the line when the doctor says, go ahead and give bicarb when the patient has metabolic alkalosis. You have to recognize that doesn't gel, right? Or the patient has hyperkalemia, and they say, go ahead and give, I don't know, some of the beta blockers, right? And beta blockers can cause some hyperkalemia. Like, well, shoot, I shouldn't give that. I should give not atenolol, I should give albuterol. Maybe the doctor wrote the wrong A medication, right? So you have to be able to differentiate that. So we are the catch-all. We are the last line between the doctor and the patient, the LVN and the patient, the CNA and the patient. It's our management of the patient. So we have to know all these things, unfortunately. Okay, and I'll let you know things that you don't have to know, right? You don't have to know doses. You don't have to know like what's the next medication to give and those things, but you do have to know that these medications are a possibility that the doctor might put in their plan to order, right? Does that make sense? Or am I get what you would expect? Well, even then, that's borderline, because expect would be kind of like, what's the next prescription? So it's going to be like, like the doctor's going to order an oral hypoglycemic. Which one of these are oral hypoglycemics, right? Or which one of the oral hypoglycemics would you notify the doctor that say, hey, they shouldn't be on this because they have this contraindication? Like they're going to order metformin, and then you look at the chart and say, yep, they shouldn't be on metformin because they have this and this, right?
Hi.
Hi.
How may I assist you?
Can you just show me real quick how you get to the chat?
You just Google it, Google Chat GPT. The free version is a 3.5 version, the paid version is the 4.0. This is what I was using when people wanted like practice math questions. Said, yeah, I can't figure out time questions. I said, give me 50 time questions, and bam. I still have to vet them because I think the time questions came out weird, but you still have to make sure that they're accurate.
Can I use the free version of it? It still works pretty good.
It's actually faster than the paid version. All right, any other last minute questions?
Good. I think I'm gonna go home and try out those diabetic medication.
So yeah, if you're cramming medications, you want to try to teach them. If it's like a first time you're learning the concept, try to teach it closed note to somebody. So that way you can then you can fill in the gaps, because you're gonna say, oh, you want to forget things you didn't that you don't want to forget on Monday. So you want to try to forget them now versus forgetting them on Monday. So try to go through it and teach it. If there's a huge amount of gaps, then you should probably teach it once or twice more, right? So the idea is to reduce the amount of gaps on the medication and such. All right, very good. Any questions on Zoom?
How may I assist you?
All right, so thank you guys. So you can ask me any questions that come up in your last minute sitting. That'd be fine.
What are all the answers for Monday?
So all the answers for Monday are